Let's go ahead and do a walkthrough of the standard personal injury documentation workup, all the different categories for the typical low impact soft tissue spinal injury. Let's do a walkthrough with that. Now, I'm not going to go into detail with each one. Obviously, there's going to be a lot of detail with each one. We don't have time to do that. We do that separately anyway. But let's just go into looking at the big picture. So if we were going to look at the big picture, and remember, this is for a low impact soft tissue spinal injury, then this is essentially what we would be looking at. So let's hit on all the major points, and I'll just touch on some of the key points relative to each one of these topics. And really, you can start to see that the more you kind of know this stuff, it just like anything, it just gets easier and easier to put together. Now, one of the reasons it's easy to begin with is because we're already talking about a low impact spinal injury. So that alone narrows so much of what we need to talk about, as opposed to just opening the door to anything. So having said that, let's go ahead and walk through this. So you got the typical administrative forms. You got the HIPAA, major medical insurance verification, accident injury verification, patient information, particularly their driver's license identification. So typical administrative forms. That takes you to the legal forms. And the big legal forms are the assignment of benefits from the patient, the attorney lien, and the limited power of attorney. Those are the three big legal forms that you want the patient to sign. That takes you to the clinical forms, looking at the patient history, family history, patient questionnaire. Remember, medication is important. The amount and the frequency is important when we talk about healing, and then especially home care. If they've had a lapse in treatment, documenting all the categories of home care becomes very important. And then we'll go into the accident injury related documents. So that's the accident injury questionnaire, which is the mechanism of injury. Pre-existing injury, or short form 36, that's for comparative analysis if the person does have a pre-existing injury. And the low impact injury factors are what we call the injury magnifiers. And then definitely the accident report to confirm all these things. Functional capacity forms, the visual analog form, the health survey. We're going to use that as a functional capacity form. That's a real good standard activities of daily living functional capacity form. For the neck, we'll typically like to use the neck disability index, and for the low back, we like to use oswestry. Remember, there's functional capacity forms for every joint in the body. So if you do need something for the shoulder or the elbow, you can just Google that and find a functional capacity form for that particular anatomy. These are the standard ones for the spinal injuries, the neck and the low back. Then there's the impairment indexes, loss of enjoyment of lifetime activities, duties under duress, and the pain disability questionnaire. Those are all done if there is an impairment. And then it takes us to standard examination procedures. We'll do a structural analysis. We'll look at the range of motion, active range of motion, passive range of motion, muscle testing. Neurological will typically include reflexes, dermatomes, cranial nerves, and the Glasgow Coma scale. That's typically what's included there. Orthopedic tests, we're going to pay a lot of attention to compression tests and extension tests relative to the mechanism of injury. Palpation, we always look at three things and quantify tenderness, fixation, and muscle spasms. When we go to x-rays, we'll pay attention to the static. So the static in the neck is the AP lateral obliques and APOM. In the lumbar, it's the AP lateral obliques. And then dynamic x-rays, and of course, that's the important ones, or the dynamic ones, is cervical. We're going to be looking at flexion, extension, left and right lateral flexion, APOM, left and right lateral flexion. In the lumbar, we will not pay as much attention to the flexion and extension unless there's pretty severe symptoms or it was more than a low impact injury. The big findings are going to be in the right and left lateral flexion. That's where the biomechanical findings are typically be for the lumbar spine. Then, of course, from there we go to the dynaram. That's a real important objective category to add to your documentation. And the blood analysis. These are objective findings. And we're looking for the sedimentation rate, and the high C reactive protein is what we're looking for there. Now, that's the core of the testing. And obviously, we want to quantify all those factors. And they stack up. When you do that, you typically have what you need. You typically have the bare minimum 7 categories. You have mechanism of injury, or you got mechanism of injury. You'll typically have subjective, hybrid, and objective findings, at least primary, if not multiple primaries and secondary findings. And that'll typically take you to MMI, which takes you to the impairment rating and the prognosis and need for future care. That gives you the bare minimum 7 categories to stop a low ball offer and have the documentation to support a high value offer. Now, there are 12 categories, but that's the 7 minimum categories. Okay. So the additional testing as needed, but it's not needed most of the time for most low impact soft tissue spinal injury patients. Like an MRI, most patients don't have a disc. That's specifically for a disc or a CAT scan, organ related. Urine analysis, when we do a urine analysis, we're looking for protein due to injuries, but that's almost always negative. So we typically don't even do it unless there was a high impact injury, not a low impact injury. Typically, NCVs and EMGs will do if there's radiating pain, but they typically come up normal. We talk about that separately. We will do for mild coma. Remember, we will not find positive findings on a CAT scan or MRI. We'll find them with behavioral tests through a neuropsychologist. And then this is the medical team that we're going to use. So we have a referring team. And remember, you always want to meet with these people first so they don't pull them out from under care or say anything negative about chiropractic, because that will look really bad with the attorney. So you want to, and we talk about how to get these people on your side separately. So you want to make sure you meet with them and they're okay with doing personal injury with you. But obviously there's more to it than that. So for pain management doctor, we use them for pain medication, muscle relaxers, anti-anxiety medication, trigger point injections. So you definitely want a pain management doctor available that you can refer to. And remember, you need to qualify these people before you send anybody anywhere. Worst thing that can happen is them start saying something negative about chiropractic care or hold off on chiropractic care until they feel better or stuff like that. And that's what you'll get if you don't pre-qualify them. Neurosurgeons are typically really good to work with. Disc bulge or herniation is what they're good for here. Neurologists for nerve conduction velocity testing or electromyography. I'm going to have them do it. I'm not going to do all this. We're going to have the specialists do it. So if they have tingling or numbness, I'm referring to the psychologist and asking their opinion. Do any further diagnostics are warranted? And I'm going to let them do what they do best, whether it's a neurosurgeon or pain management or a neurologist. Orthopedist, we like to use them for extremities and joint injuries. Generally, they're a little bit harder to deal with. Don't work with chiropractors as well. I'll use them for extremities and joint injuries. The neuropsychologist, that's for behavioral testing for mild coma. That becomes real important if the patient has had any blurred vision or saw stars or temporarily blanked out, or, those are all symptoms of a mild coma. And that needs to be followed up on accordingly. That's behavioral testing. Daily treatment documentation. So remember, when you do the daily treatment documentation, there's the SOAP notes. Most people get the pain scale right. Most people, the visual analog scale, pain scale. Remember, you do need 2 E&Ms. You do need 2 E&Ms for your for the objective portion. And we typically will do pain and tenderness, muscle spasms, or fixation. And then the analysis is the diagnosis that continues until the next re-exam, and the plan is your treatment that you put in place that stays the same, that continues until the next re-exam. And those should not change until you do the next re-exam to know what the biomarkers are and what therapeutic protocols you're going to use now and how they're responding to care. So the re-exam documentation, you want to do that every 12 visits or every 90 days, whichever one comes first. So in the beginning, your first 1, 2, 3 re-exams will typically be within 12 visits. If it spreads out, it might get to 90 days. So you definitely want to redo all positive initial findings, functional capacity indexes. This is when you do the functional capacity indexes. That's at the initial exams and the re-exams. And you may need to do an interim medical report. Usually it's for an insurance company, or even sometimes the attorneys will just ask, hey, what's the status of the patient? And that's when an interim medical report that's when it's valuable. And of course, we go over the categories of what to include in an interim medical report. End of care protocol. Final exam is at MMI based on the science of the 3 phases of healing. We go into the details of that. The patient's released, either they're 100% normal or they're at maximum medical improvement with an impairment rating. And then you want to continue palliative care. This becomes real important, especially if you have cases. It looks real bad if you go to MMI, give the impairment rating, and then the patient doesn't seek any further care at all up until they settle. That looks really bad. So there should at least be on some form of continued palliative care at that point, not just clinically, but administratively and legally. Upon request, impairment ratings. So remember, we don't just hand out impairment ratings like candy and a narrative report. But remember, if your attorney is not asking for an impairment rating or a narrative report, that's because you have an attorney who's in a state of unconscious incompetence and he does not know any better, because those are the 2 most important components for his to support his injury award if they're done right. Unfortunately, most of the time they don't ask for them because they're not done right and they don't see much value in them. So and that's when, of course, you need to do your educational sales to make sure they understand that they're missing major components of this injury award. So this is just a real quick summary. And of course, we go into the detail of all of these categories, but this is a real quick summary from administrative. Remember, this is the low impact soft tissue spinal injury. So we can narrow it down like this a lot more. So we got the administrative forms, we got the legal forms, the clinical forms, accident-related documents, functional capacity forms, impairment indexes. And of course, we go over how to do all of these things individually. Standard examination procedures from structural to active passive range of motion, muscle testing, neurological testing from reflex dermatomes, cranial nerves, orthopedic testing, palpation, tenderness, fixation, muscle spasms. And then the x-rays will pay attention to static and dynamic, with dynamic being much more important. So we'll make sure we have those done and documented properly. And then that's supported with the dynarom. And remember, the dynarom is really good for an objective analysis of muscle spasms, primary and secondarily, so for supporting altered pathological spinal biomechanics. Same with the blood analysis. It's 100% objective. It's secondary for altered spinal biomechanics, not primary. And then any additional testing, which is rare. Usually you're in the typical low impact soft tissue spinal injury, we're typically not using any of these tests, MRI. And then, of course, the medical team, that is important. That is important. So if you have any of these other symptoms, it's always good to make sure you have your medical team in place so you can refer to get that person's opinion and any further diagnostics that may be necessary. That supports the case. And that's real important, especially from a legal perspective, the attorneys and the legal perspective. That is very important. And it's not just the chiropractor involved in everything. And these are the typical providers that we'll use and who we refer them to. That's the typical SOAP note to substantiate the need for care. Of course, we go into detail with all that. And then, of course, the re-exam procedures to the end of care protocols and treatment procedures. And then it all ends up with the MMI impairment rating and then the narrative report. And then that narrative report, remember, there's 12 categories, 12 highly specific categories with multiple subcategories that tells the story logically, sequentially, and supports the injury award. What's happened to the patient. So there you have in a nutshell all these categories, and of course there's a lot more to them individually.